Welcome to our unit on healthcare and disability management. In this unit, we will discuss appropriate medical intervention resources, healthcare benefits and delivery systems, health promotion and wellness concepts and strategies for people with chronic illness and disability, insurance programs such as Medicare, Medicaid, group and individual, short and long-term disability, personal injury, no-fault liability, disability prevention and management strategies, workers' compensation laws and practices, managed care concepts, and forensic rehabilitation. Disability management is defined by the Certification of Disability Management Specialists Commission, CDMSC, as the prevention and minimization of the human and economic impact of illness and disability for the employee and employer to optimize the quality of care, productivity, organizational health, and regulatory compliance. Disability management services include the following activities: disability assessment and evaluation, case management, return to work intervention, labor market analysis, career exploration and counseling and reporting, plan development and report preparation. Disability management expectations include ensuring that employees can continue to work productively and provide cost containment for the employer. Schrey and Lacerte in 1997 indicated that DM services are more effective when provided at the worksite as often as is possible. Addressing the emotional, physical, medical, vocational, and organizational concerns of individuals with disabilities. Disability prevention, safe return to work, and rehabilitation programs are all involved in achieving this goal. And planning, coordinating workers, management, healthcare providers, rehabilitation professionals, and insurance carriers. To minimize the impact of illness and disability on both the employer and employee, disability management emphasizes prevention, ergonomics, safety, employee assistance plans, wellness, and positive work practices such as lifelong learning and establishing a work-life balance are key components of prevention. Early intervention. Case management and early intervention involve the employer, employee, the union and/or employee representative, medical personnel, and insurance carrier working together to anticipate and resolve potential problems. Return to work. Transitional alternative duties, ergonomics, attention to psychosocial factors, and follow-up, including safety and productivity, are all factors that can influence a successful transition back to work. Absence management. Anticipating the possibility of absences early, whether involving sick pay, family and medical leave, or unauthorized time off, allows interventions to be set up to reduce the chances of further disability or more significant work interruptions. Identifying and planning for absences can positively contribute to the employee's overall productivity and value. Presenteeism. Staying at work while experiencing health problems can result in slowed or decreased performance, reduced work capacity, extra training time, errors, and inadequate work results. Evidence-based practice. Selecting research-proven disability management interventions, documenting practitioner recommendations and results, and objectively evaluating outcomes gives consumers an advantage when returning to work. Benchmarks. Established by the employer, these are performance standards used to measure worker progress and typically include work quality, worker productivity, and frequency of absence. Metrics. Also established by the organization, metrics are the tools used to measure individual performance and activities against benchmarks. Direct costs. Workers' compensation, rehabilitation, insurance premiums, and litigation are examples of direct costs. Indirect costs. Lost time, decreased productivity, recruitment, retraining, overtime, and accommodations are considered indirect costs. Stakeholder satisfaction. It is important that everyone involved is satisfied with the end result of the disability management process. Critical stakeholders could include the employer, the employee, insurance companies, medical providers, and/or in-house or outsourced providers. Recognition of the needs of an aging workforce. As workers age, abilities and capabilities can change. An awareness of suitable strategies to accommodate these changes can impact prevention, health, and well-being as workers remain in the workforce longer. An effective disability management program integrates services. Human resource practices are those which may address compensation, absenteeism, presenteeism, hiring, retention, the Family and Medical Leave Act, or FMLA, employee assistance programs, EAP, and coordination of benefits. Medical and health services refer to physician support, healthy workforce initiatives, drug benefits, and transitional return to work restrictions. Risk management practices include employee health and safety, workplace safety, ergonomics, compensation, and administration. Education involves training and teamwork and applies to staff at all levels, and advocacy and interdisciplinary approach which enhance the process by raising awareness as well as coordinating the work of professionals across appropriate disciplines, such as medical, social services, rehabilitation counselors. The Workers' Compensation Act is the federal legislation which forms the basis for workers' compensation systems throughout the United States. The Wisconsin Department of Workforce Development describes the purpose of workers' compensation as a method to restore an injured worker as nearly as possible to the pre-injury earning capacity and potential. Both the worker and the employer benefit from engaging in return-to-work programs after a worker sustains an illness or an injury related to the job. According to the Job Accommodation Network, or JAN, research supports the idea that return-to-work strategies reduce workers' compensation costs because they help returning workers become productive sooner. Workers' compensation is mandated by each state individually. Similarities from state to state include the definition of an injury, the provision of medical coverage related to the injury, and wage and benefit compensation. Workers' compensation laws also provide benefits for dependents of those workers who were killed because of work-related accidents or illnesses. Some laws also protect employers and fellow workers by limiting the amount an injured employee can recover and by eliminating the liability of coworkers in most accidents. The goal of workers' compensation is to promote maximum function and the return to productive, suitable employment. This is accomplished by conducting a needs assessment, coordinating medical and vocational rehabilitation services to assist in recovery and maximum medical improvement, or MMI, identifying transferable skills based on residual functional capacity, and assisting in return to gainful employment using the following return-to-work hierarchy. Return to the same job, same employer. Return to different job, same employer. Return to same job, different employer. Return to different job, different employer. Formal training. As you can see, the goal is to use residual skills and achieve placement as soon as possible. The following groups of employees are typically excluded from workers' compensation laws. Railroad workers, federal employees, longshoremen, and harbor workers have separate workers' compensation laws. Domestic, agricultural, religious, and charitable occupations and professional athletes are exempt. Some employers with fewer than a specified number of employees, usually 1 to 5, varies per state. The following terminology is used in workers' compensation cases. Temporary total disability. If an employee is totally unable to work for a period of time but is expected to recover and return to work, he or she can receive weekly income replacement benefits after a waiting period. Temporary partial disability. These benefits are paid when the employee is partially disabled from his or her regular job temporarily. The employee usually works part-time or in a lower-paying position while recovering. Permanent partial disability. This is a lump sum payment in many states based on a fixed schedule depending on what part of the body is injured. Non-scheduled injuries such as head, back, heart, etc. are computed based on wages lost between pre-injury and post-injury earnings. Permanent total disability. This is paid if the employee is totally and permanently unable to perform suitable employment. Often it is paid throughout a person's post-injury life, but in some states they place a limit or dollars or time on benefits paid. Managed care is defined as the integration of both the financing and the delivery of health care within a system that seeks to manage accessibility, also called utilization, cost, and quality of that care. By 1995, as many as 50% or more of workers' compensation claims were handled through a managed care arrangement. Medical report cards are a way for case managers to determine which medical facility to refer clients to. The National Committee for Quality Assurance created the Health Plan Employer Data and Information Set, which provides guidelines to measure the quality of care provided by healthcare plans. This tool helps professionals and individuals evaluate potential insurance programs. The following cost containment strategies are used in managed care to manage cost, accessibility, and quality of care. Utilization review. The purpose of utilization review is to prevent inappropriate or unnecessary hospitalizations. UR case managers monitor the healthcare process before, during, and after hospital stays. They determine whether hospitalization is necessary in non-emergency situations, how long the stay should be, plan the discharge sometimes, and perform a retrospective review to ensure charges are correct. UR case managers are typically nurses, and the job is almost entirely clerical. Information is gathered through physician reports and contact with case managers, physicians, and sometimes even the patient. Provider choice. Provider choices may be limited. Lower cost plans have fewer choices, and higher cost plans have more choices. Provider change. Same as above, more expensive plans allow changes more readily. Medical fee schedules. Fee schedules indicate the maximum reimbursement for procedures. Regulation of hospital charges. The state may regulate hospital charges to various extents depending on the state. Medical fee schedules are available if hospital charges are not mandated. Treatment guidelines. These guidelines indicate what type of treatment is appropriate for certain injuries, including number of lost workdays and transitional workdays. Thoughts about managed care are conflicting. Although it has reduced healthcare costs in some areas, there are many problems with managed care. Both members and doctors have been inconvenienced by utilization review processes. Since managed care limits choices, it can result in decreased customer satisfaction and the idea that managed care services are of a lower quality or that needed services are not allowed. Health insurance programs in the United States are influenced by managed care concepts. Programs seek to provide quality care while managing accessibility and cost. In this section, we will provide an overview of the following major types of health insurance programs: Health Maintenance Organizations, HMOs, Preferred Provider Organization, PPO, Point of Service Plan, POS, Fee-for-Service or Indemnity Plans, Medicare, Medicaid. Medicare. Individuals who receive Social Security Disability Insurance, SSDI, are eligible for Medicare coverage after they have been entitled to SSDI payments for 24 months. There are 3 parts to the plan. Part A, hospital insurance, is available with no premium for people who are receiving an SSDI payment. It helps pay for care in a hospital, care at a skilled nursing facility, home health care, and hospice. There are deductibles, benefit periods, and coinsurance amounts. Part B, outpatient services, covers physician services, outpatient hospital services, certain home health services, durable medical equipment, and other items. Generally, physicals, eyeglasses, hearing aids, dental, and custodial care are not covered or the coverage is limited. There are deductibles and copayments. Part D, prescription drug coverage, covers retail pharmacy prescriptions. To be eligible for Part D, an individual must also be eligible for Part A and/or Part B. In addition, Part C, or Private Medicare Advantage Plan, includes services offered by Parts A, B, and D with additional supplemental insurance. The Social Security Administration offices help people enroll and can provide general information about Medicare. For a link to Medicare, check the additional resources for this module. Medicaid. Medicaid is a federal health care program for those who have a lower income, for families and children, for the elderly, and for people with disabilities. It is funded jointly by the federal government and individual states and is managed by states. Eligibility requirements for Medicaid vary by state, but people with disabilities are eligible in every state. For a link to Medicaid, check the additional resources for this module. We can view healthcare delivery systems in terms of people-centered care and integrated services. The World Health Organization offers the following definitions. People-centered care is care that is focused and organized around the health needs and expectations of people and communities, rather than on diseases, whereas patient-centered care is commonly understood as focusing on the individual seeking care, the patient. People-centered care encompasses these clinical encounters and also includes attention to the health of people in their communities and their crucial role in shaping health policy and health services. Integrated health services involve the management and delivery of quality and safe health services so that people receive a continuum of health promotion, disease prevention, diagnosis, treatment, disease management, rehabilitation, and palliative care services through the different levels and sites of care within the health system and according to their needs throughout the life course. An effective healthcare delivery system requires qualified healthcare workers, a high-quality infrastructure, ready access to medicines and technologies, adequate funding, quality healthcare plans, and reliance on evidence-based practices and policies. The healthcare delivery system consists of facilities, entities, and practitioners. Common facilities include hospitals of different types, each offering different services. Examples include primary care hospitals, tertiary care facilities, acute care centers, subacute care for people who need to be hospitalized but who are not critically ill, swing bed care for people waiting for availability in a skilled nursing facility, government-run facilities for war veterans or the Veterans Administration, specialty hospitals such as cancer or children's hospitals or state-run mental health facilities. Ambulatory surgery centers can perform minor surgeries. Skilled nursing facilities such as nursing homes are Medicare-approved facilities that provide 24-hour care to non-acute patients. Home health agencies provide in-home nursing care. Freestanding substance abuse facilities provide inpatient care for people who are seeking treatment for substance abuse. Hospices provide palliative care for terminally ill patients. End-stage renal disease, or ESRD centers, provide care for people with ESRD. Many professionals play a vital role in the rehabilitation process. Following are some of the more common fields that interact with clients of the vocational rehabilitation system. Physical medicine, a recognized medical specialty dealing with the treatment and rehabilitation of people with disabilities. Through drug therapy, corrective surgery, and patient training, physical medicine brings the client up to maximal functioning. A person who specializes in physical medicine is called a physiatrist. Rehabilitation nursing. Rehabilitation nurses assist physiatrists and other ancillary medical specialists such as physical or occupational therapists. Some rehabilitation nurses are active in disability management for people receiving workers' compensation. Acting as case managers, nurses serve as liaisons with employers, insurance agencies, medical teams, and families to help people return to work as soon as possible. Prosthetics or orthotics. These specialties are devoted to design, modification, and maintenance of artificial devices that increases a person's functional capacities. Orthotists fit patients with orthoses or braces that compensate for numerous disabling conditions of the spine and extremities. Prosthetists fit clients with prostheses to replace missing limbs and limb segments. Physical therapy, or PT. The goals of PT include increasing or maintaining joint range of motion, increasing muscle strength, relieving pain or muscle spasms, or teaching techniques of ambulation. People with a wide variety of disabilities utilize PT. Occupational therapy. OT services include the design, fabrication, and application of splints, sensory motor activities, the use of equipment, pre-vocational evaluation and training, and consultation concerning adaptations of the physical environment for people with disabilities. Speech-language pathology and audiology services. SLPs identify, assess, treat, and prevent speech, language, voice, and fluency disorders. In addition, SLPs participate in assessment and treatment of swallowing disorders. Individuals with a wide variety of diagnoses that affect communication, language, and/or speech can benefit from SLP services. Examples include stroke, brain injury, degenerative diseases, learning disabilities, cerebral palsy, and autism. A final note related to healthcare. Alternative medicine is non-traditional healthcare, which includes practices such as massage, audiology, herbal medicines and supplements, reflexology, and aromatherapy. These are used for preventative care and to treat chronic and acute medical conditions, but tend to be funded by those utilizing them and not typically covered by insurance. Private rehabilitation is a term referring to private, as opposed to public, employees providing a rehabilitation service that demands a fee. Insurance or forensic rehabilitation are components of private rehabilitation. According to Black's Law Dictionary, forensic rehabilitation is the practice of rehabilitation principles in legal settings. Rehabilitation counselors may be called upon to testify in court cases, or they may make a practice of forensic rehabilitation as a substantial portion of their work efforts. In a forensic setting, counselors must possess self-confidence, emotional stability, and remain objective in forensic settings. Vocational experts are often called upon to determine how a disability has affected a person's earnings capacity. Such professionals must be unbiased and objective when giving expert testimony, as opposed to assisting with life care planning. CRCC requires that when a counselor changes roles, specifically when acting as an expert, they need to be prudent about the frequency as well as being transparent with clients about job duties and professional expectations when fulfilling different roles. For more information, review the CRCC Code of Ethics, Section F, Forensic Services. Typical duties of the rehabilitation counselor as a vocational expert include interviewing the client and gathering relevant personal, family, social information, and a thorough vocational history, reviewing and integrating reports from all sources of information regarding the client, completing a transferable skills analysis, selecting, administering, scoring, and interpreting appropriate assessment tools such as achievement and aptitude tests to determine level of functioning, referring clients to other service providers as necessary, analyzing, synthesizing, and integrating all relevant information into a report about the worker's background and current functional level with appropriate rehabilitation and/or vocational recommendations, performing job analyses and labor market surveys to identify relevant wage and earnings information, administering earning capacity and loss of earning capacity evaluations, determining the costs of rehabilitation, utilizing relevant resume data and information in the formulation of an opinion, and presenting written or oral reports in a variety of settings including individual consultations, depositions, and/or hearings. Referrals for forensic rehabilitation services come from a variety of sources, including attorneys, claims adjusters, tort auto, product, medical malpractice insurances, disability, age, employment, gender, and racial discrimination cases, the Social Security Administration, state or federal VR systems, service appeals, the Department of Veterans Affairs service appeals, family law, marital dissolution and child custody, employment law, ADAA, wrongful termination, harassment, employability, etc., trust fund management, K-12 educational professionals, IDEA services, and other. Vocational rehabilitation services were first provided to civilians under the Smith-Fess Act, also known as the Vocational Rehabilitation Act of 1920. The law dictated that cooperative agreements should be developed within the existing workers' compensation boards and commissions in all states that provided workers' compensation services. As discussed earlier, federal legislation mandated that other disability groups were also to be served. Elizabeth Ross, an article titled Rehabilitation Workmen's Compensation, voiced support for the movement whereby the value of vocational rehabilitation was recognized within workers' compensation. She stated that rehabilitation is more than medical care. It is more than money. Rehabilitation is that ingredient which gives perspective and meaning to the whole workmen's compensation program. In 1975, California mandated an addition of vocational rehabilitation services to the medical services already provided in the state workers' compensation laws. Each state has its own workers' compensation law, and as a result, there is variability in benefits from one state to another. Vocational rehabilitation services are central aspects of the workers' compensation law in some states, less so in others. There are also federal workers' compensation programs where benefits are provided to individuals with work-related disabilities. Private for-profit rehabilitation practices started to emerge around 1976. Clients may interact with both the workers' compensation and private rehabilitation systems, but should be aware that these are two separate entities with differing service emphases. The public rehabilitation system and the private rehabilitation system tend to operate independently of one another and occasionally interact when an injured worker who is no longer covered by workers' compensation comes into contact with a public rehabilitation system, or when an attorney sends an injured worker to public rehabilitation for an evaluation or assessment. There are fundamental similarities between public and private vocational rehabilitation practitioners, including a common rehabilitation philosophy, adherence to human service ethics, knowledge of laws affecting people with disabilities, familiarity with services and service processes, and general education and career experience histories. Other similarities include familiarity with medical and psychological aspects of disabling conditions, awareness of psychological and vocational adjustment needs of people with disabilities, familiarity with and use of evaluation and assessment procedures, familiarity with and use of occupational information, the world of work and job analyses, knowledge of community and assistive resources, familiarity with methods by which to establish rapport, general knowledge of job placement methods and techniques, ability to collect information, identify trends and significant differences, plan and modify programmatic strategies, report outcomes and implement change, ability to recognize the need for, recommend referral for, and or provide appropriate rehabilitation services, and acceptance of occupational, social, and personal responsibilities associated with professional accountability. There are many differences between public and private rehabilitation practices, but many of them are either specific to the type of employment setting. Following are the most notable. Caseload size. Private sector vocational rehabilitation counselors typically manage caseloads consisting of 25 to 45 clients. In contrast, publicly employed VR counselors regularly have over 100 clients on their caseload. Additionally, Veterans Administration counselors may handle more than 200 clients at any given time. Client eligibility. Eligibility in the private sector depends on the source of fees used to pay for services. Public agencies serve clients deemed eligible by legislative mandates. Rehabilitation goals. The goals of private sector agencies is disability prevention or post-disability intervention as soon as possible following onset of disability, with the goal of restoring a worker to their previous level of functioning. Public sector agencies provide services with the goal to maximize a client's potential. Rehabilitation services. Private rehabilitation counselors provide services that have been requested and authorized by the funding source. Public sector staff typically provide whatever services are necessary to achieve an employment goal as authorized under legislation. Job placement. Due to their goal of getting workers back on the job as soon as possible, private sector rehabilitation counselors spend much more time on placement, labor market analyses, and job and task analyses than do public rehabilitation counselors. Forensic involvement. Private sector rehabilitation counselors are much more likely to work with cases that require vocational testimony in the judicial system. Case documentation. The private sector's case records reflect the standards required by referring and/or funding sources, regulations as appropriate. For example, workers' comp, personal injury policy, the specific organization. The public sector has national standards to follow for reporting procedures. Funding sources. Private, nonprofit rehabilitation programs rely primarily on service and product contracts with public agencies and businesses and industry. And private, for-profit agencies generally receive revenue through service contracts with public and private insurance funds, job incentive programs, and private fee-paying clients. Public agencies are funded by tax revenues. Once gainfully employed, clients become taxpayers, thus providing a return on the public investment. Administration. Private sector rehabilitation services providers or provides operate under a fee enterprise or a free enterprise system, which allows them to be nimbler and to allow for more rapid change. Public rehabilitation is administered by state federal programs and are required to follow governmentally established policies and procedures by the U.S. Department of Education's Rehabilitation Services Administration. This can have the effect of reducing programmatic changes and flexibility. Personnel. Private sector rehabilitation hiring policies are much less uniform than those of the public sector. However, both hire credentialed professionals. In private rehabilitation, professionals may come from a variety of backgrounds, such as nursing, physical therapy, and/or mental health counseling. Salaries and promotions of rehabilitation counselors in the private sector are often based on placements and billable hours, whereas salaries of public rehabilitation counselors are typically based on length of service and performance. Public and private rehabilitation both involve assisting people with disabilities with employment, require counseling skills, and involve some form of evaluation and plan development. Activities may be similar, but priorities can differ. Employers often differ in their handling of disability management. Vocational rehabilitation professionals should be prepared to address each situation according to the employer's disability management philosophy, DM program quality, scope of services, support services offered, and orientation toward employee return to work. Both training and experience are used to determine the credibility of vocational experts in court. According to Rubin and Rossler, fundamentally vocational experts must demonstrate the use of procedures and methods generally endorsed by practitioners in the field. This can be accomplished by utilizing textbooks and articles to justify rehabilitation practices. It is not adequate to give an opinion based solely on a counselor's education and experience. According to DiMatteo, Marsick, Krause, and Berlin 2009, there are 7 core competencies for practitioners in forensic psychology. Substantial foundational knowledge of the psychological domain, including core knowledge related to the specific field in which one practices, vocational rehabilitation, clinical and/or development and/or social psychology. Research methodology, including research design and statistical analyses. Expertise in conducting original research. Legal knowledge, which includes how the legal system works, case law, and procedural processes relevant to forensic psychology. Integrative psychology. Legal knowledge, including areas such as eyewitness testimony, jury decision-making, admissibility of scientific testimony, forensic assessment measures and techniques, and the treatment of offender populations. Professional ethics. Training in forensic psychology. Life care planning is related to the medical and catastrophic case management services that rehabilitation counselors sometimes provide in the private sector. One example of a catastrophic case would be in the event of a spinal cord injury. The injured person, his or her family, the insurance carrier, and the legal system use life care plans to estimate and plan for long-term needs and costs associated with a severe disabling condition. Ideal preparation for the development of life care plans includes training in assessment, independent living, rehabilitation technology, and experience with catastrophic injuries.